Arrhythmias are very common. Almost every human being will experience some sort of arrhythmia during the course of their lifetime.
Welcome to the 6th episode of the second season of the CHC podcast. I am Anna Jaworski and a heart mom to an adult with a single ventricle heart. I am your host today. Today's show is devoted to World Heart Rhythm Week. Many members of the CHD community suffer from rhythm issues such as a-fib, ventricular tachycardia, also known as VTAC, atrial flutter, complete heart block, Wolff-Parkinson-White syndrome, long QT syndrome or LQTS, premature atrial contractions or PACs, bradycardia or supraventricular tachycardia, SVTs, to name some of the most common problems we see in the CHD community. According to upbeat.org, heart rhythm disorders can be divided into three broad categories: electrical, circulatory, and structural. For today's episode, we are going to focus most of our attention on electrical problems with the heart. It's important for us to understand what some of these rhythm issues are and how they can be managed and treated. With us today is a panel of experts. Dr. Samuel Asivatham, Dr. Sam, is a cardiac electrophysiologist from the Mayo Clinic in Rochester, Minnesota. He's also the program director for the Clinical Cardiac Electrophysiology Fellowship and director of strategic collaboration for the Center for Innovation at Mayo Clinic, Rochester, Minnesota. Dr. Sam has a number of innovative interests and research projects he's been involved in, including, but not limited to, development of an epicardial electroporation for arrhythmia renal nerve stimulation, for the treatment of neurocardiogenic syncope, and the development of a novel circuit to prevent clot formation during radiofrequency ablation procedures. Ayrton Beatty is a bereaved sibling of their brother Edward, who passed away suddenly in his sleep from an undiagnosed heart condition. In recent years, they were diagnosed with drug-induced long QT syndrome. This has been caused by their medication for their chronic long-term physical health problems. Sadly, they had to fight to get this diagnosis as doctors refused to take their symptoms seriously. Ayrton is a volunteer for the CHC podcast. And Frank Jaworski, the love of my life, is a certified registered nurse anesthetist, or CRNA, who works at Baylor Scott & White Hospital. Frank has been a CRNA for almost 24 years. Although Frank works all over the hospital, giving anesthesia and doing pain management, one of his favorite places to work is in the electrophysiology lab. Frank is also married to me, and we have a child with a single ventricle heart, and he is a patron of Hearts Unite the Globe, which sponsors this podcast. We're going to start with one question for all of you panelists. As a member of the CHD community, please share with us how rhythm issues affect your life. Dr. Asivatham, welcome to the CHC podcast.
Thank you. It's a pleasure to be here. Most of my work is with patients who have either fast or slow heart rhythms. And these may occur in either patients with normal hearts or structurally abnormal hearts, like with congenital heart disease. Frequently, the presenting symptom is palpitation. Other times, it can be fainting or syncope, which most often is because of an rhythm abnormality in the lower chamber, the ventricle. After evaluating the patients, finding out if there's any precipitating factor, like a problem with their electrolytes or a medication that they took, if that's excluded, and simple medications are not working, maybe 3 to 4 times a week, we perform procedures like ablation or cardiac pacing or placement of defibrillators. That's my main interaction with patients with heart rhythm disorders.
One of the things that we didn't mention when we were introducing you is that you are also certified to work with adults with congenital heart disease. Is that why you see so many CHD patients?
Yes. So among heart rhythm specialists, almost every electrophysiologist will perform procedures or work with patients with congenital heart disease. But in the United States, about 10 or 15 heart rhythm specialists, and in Europe, about another 10, focus work with congenital heart disease. It is a unique opportunity to help patients because not only do you have to have the skills and diagnostic methods to find out what the heart rhythm problem is, but you have to be able to change how you approach it when the heart itself is abnormal. The way I explain it to some of our trainees is it's like you've learned to drive a car, a truck, and you're pretty good at it, but you learned it in Chicago. And now you have to go do that in Moscow or Tel Aviv or Chennai, India, where the rules are a little different. So you have to learn the rules, but you basically have to drive in that situation as well.
Are you driving on the wrong side of the road too?
I've been known to do that, but fortunately, very brief experiences like that.
But I imagine as an electrophysiologist working on patients with all different kinds of heart defects, sometimes you feel like you have to be on the wrong side of the road to get the problem fixed.
It is true. And that's why preparation is very important. So, a team approach where the primary congenital heart physician, the radiologist who's done the imaging in the patient, and a discussion so that you practice the procedure in your mind. And sometimes we use virtual reality or 3D printed hearts to fully understand where our catheters are going to go when there is congenital heart disease. And it makes it that much easier when we're actually doing the procedure.
I know. I just think it's amazing what can be done with those 3D printed hearts now. Do you find that you frequently will print up one of those hearts? Because that is a rather laborious project, isn't it?
No, it's gotten easier. I would say right now it's almost all ablations and devices I do in patients with surgically treated congenital heart disease. I will either have a 3D printed heart or a virtual reality environment from the CT scan of that patient's heart as part of the prep before doing the procedure. I would say maybe 99% of my cases, we will have one of those.
Wow, that's amazing. Okay, well, I know where to go if I have a congenital heart defect and I have a rhythm problem. I
Mm,
know the
mm,
man I want to work on me.
Thank you.
Ayrton, welcome to the CHC podcast.
Thank you for having me on as a guest.
I know it's always fun to have you on as a guest. I'm used to you being a host lately or a producer, so it's kind of fun to have you on as a guest. Please share with us today how rhythm issues have affected your life.
I was diagnosed with drug-induced lung QT syndrome a few years ago. For me, I have lots of issues with bouts of dizziness. I go really lightheaded. I do completely black out at times, sometimes without warning, or just drop on the floor, which can be scary.
I would say it would be terrifying. Yes,
Yeah, so I tend not to leave the house now unless I've got someone with me.
that makes sense.
Yeah, so I've lost quite a bit of independence due to it.
And we
Uh,
know that Edward might have had a rhythm problem that was just undiagnosed. Isn't that true?
Yes, because of how Edward died. Obviously, with rhythm issues, you can't detect them after that person has passed away. So, with his cause of death here not actually being officially registered, so it's been left as an open verdict. So, if it was an electrical issue with the heart, we will never know. And because we were both adopted from different biological parents, there's not a genetic link.
There's not a genetic link, and yet, had it not been for Edward's passing the way he did, you might not have been the advocate you were for yourself to get diagnosed. Isn't that true, Ayrton?
Yeah, that's very true. There's no way I would have fought as hard as I did to get my heart tested. I probably would have just sat back. And even this last month, my GPs were telling me that my ECG readings were nothing to be worried about when my QT interval had increased by over 200.
Oh my goodness. They're telling you it's something to be worried about, even though you have episodes of syncope or fainting, as we
Yeah,
say in the vernacular, and you have completely had to change your lifestyle, they're telling you not to worry about it?
Yeah.
Well, that concerns me.
Yes. Yeah. They've actually now started to take me off my antidepressants, which they think is the main medication that's causing it.
Are they not worried about what problem that may cause as far as your
No,
quality of life?
it's a tough one because it's either have me deal with the symptoms of my borderline personality disorder and my depression, or have me deal with the drug-induced long QT syndrome. And to be honest with you, I would rather deal with the symptoms of my depression and borderline personality disorder.
It's good that you're clear on that. And I'm glad you're seeing somebody to help you. Thank you for explaining that to everybody. Frank Jaworski, welcome to the CHC podcast, sweetie.
Thank you.
I'm happy you're here today. And I would like for you to explain to everybody what type of rhythm issues have affected your life.
Well, our youngest, Hope, obviously born with a congenital heart defect, has had rhythm problems to some degree, but mostly it's more a case of prevention. She's had Holter monitors multiple times to watch for rhythm problems after surgeries. I know that she has more than a usual burden of PVCs for a person her age. And when she had her revision of her Fontan surgery at the age of 17 years, they did do a maze procedure also to help prevent rhythm problems. So we're constantly aware. I've spoken to her before about taking it seriously if she has palpitations or lightheadedness and to let somebody know immediately. It's a thing we look out for because the likelihood of her needing the pacemaker or an ICD at some point in her life is much higher than the average, obviously. So very
Well,
conscious of that, very aware.
what concerns me, love, is that both you and she have had arrhythmias in the past and neither one of you have felt them.
That's true. I've experienced SVT several times. I'm on medication for it currently. I'm on cardizem and metoprolol, and it seems to have it under control. I have not had recurrence of it since then. But the first time I had SVT, I was at a clinic visit for an unrelated thing, and they took my vital signs and said my heart rate was 150, and I found it hard to believe. So what they did was they made sure that immediately after the clinic appointment, I went to the emergency department, which you took me there, and
Hmm.
we handled things at that point. But only one time during the entire progress of having SVT episodes have I ever felt anything like a symptom, and that was just fatigue. I felt sleepy
Hmm.
and tired after having
Yeah.
been in SVT for about 4 hours. Never had palpitations and never had any chest pain or shortness of breath. And my cardiologist told me that that's actually a good thing, that it shows that I kind of had a stress test from having this long-term SVT, and that it's unlikely that I have any kind of coronary blockage because of that, and I'm happy to hear that.
Yeah. But I remember being at the cardiologist with Hope, and she would be connected to the EKG machine, and she would be having arrhythmias, and the doctor would say, "So how do you feel?" She was like I always do. She just didn't feel
Right.
anything, just like her dad. So I'm glad that both of you are being monitored regularly because rhythm issues could be a bigger part of our lives. And it seems to me that since you do have things under control with your own heart, and Hope is now an adult and we don't have as much control over things with her, that the bigger experience you have with rhythm issues is as a CRNA. Can you tell us a little bit about that?
Sure. I do wanna mention also that concerning my own rhythm issues is that, one small change to my life is that I now wear a smartwatch that monitors my heart rate and has alarms set so that if I go excessively tachycardic, it'll go off. My wife has convinced me to wear that device, so I do wear that, and, I'm aware of that device every day. Personally, professionally, as a nurse anesthetist, I started about 20 years ago working occasionally in the electrophysiology lab, administering sedation or general anesthesia for procedures there. And I got to enjoy it. I like the cases. I like the people that I work with. I like the nature of the job that I do there. I've learned a little bit practically about dysrhythmias and ablations and placement of devices. And I try to use that knowledge to make things better for the clinical team taking care of the patient and, of course, for the patient themselves.
Right. You work with patients who are having ablations, who are having Watchman devices put in.
Sure.
Sorry,
And of
trouble
course,
to
makers and ICDs
right.
also.
Okay, great. Ayrton, most of my friends with long QT syndrome or LQTS have pacemakers, medication, or implantable cardiac defibrillators, ICDs, but none of my friends have drug induced LQTS, except for you. You're the only one. So I'm wondering, how are doctors managing your LQTS? And we did just mention before how they're maybe wanting to take you off of medications, but can you talk to us a little bit more about how you're being managed for your condition?
Well, like Frank, I also wear a smartwatch that I used to track my pulse rate. It also has alarms to make sure I don't go above a certain pulse rate. I'm banned from going swimming because that's one of the worst things, apparently, for people with LQTS because of the stress it puts on the heart muscles. I have to limit the amount of physical activity I do, again, because I can't get my heart rate elevated. Because if I do, I basically overheat, I start vomiting, I just start feeling sick. I feel like I'm going to collapse. I just have to be really careful with what I'm doing.
Ayrton, does that mean that even climbing the stairs or walking uphill is too much stress for you?
Climbing the stairs, I'm okay with. Climbing hills, I have to watch, which is really awkward considering I live in Scotland and
Yes.
it's not exactly the flattest country in the world.
No, it's not. Wow. Yeah, it's not. There's a lot of hills, and yeah, that could be a challenge. So how do you negotiate that?
I just have to take my time. I have to know my limits. And when I start feeling a certain way, I check my pulse on my smartwatch and if it's over so many beats per minute, I have to stop, take a few breaths, wait for it to drop back down before I can start walking again. Because even going from the shops to my house, it's an uphill climb. So some days
Wow.
that can be really difficult.
Yeah. Yeah. Wow. Okay. What did people do before we had these smartwatches, right?
Yes.
I'm glad that both you and Frank have the smartwatches, and I'm glad that you are self-aware enough that you have figured out what it is you have to do. And you said you also make sure that when you're going out that you will have somebody with you, right?
Yes, because before I had my diagnosis, I wasn't aware of what was going on with me.
Mhm.
And even in the middle of winter, I would be dripping with sweat and I would take off my thick winter jacket, would take my jumpers off. I'd be standing in the middle of the street in just my t-shirts and people would be looking at me like I was weird. But I just felt so hot and so sick. I just needed to cool down so quickly. It was the only
Yeah.
way I could do it.
Mhm. And now that you're more self-aware and you have your smartwatch, do you find that you don't get as hot and sweaty as quickly or as often?
Yeah, yes.
Okay.
And I think as well, the main issue I had with the doctors not wanting to believe me was the fact I was also severely overweight as well.
Right, but you've lost a lot of weight, haven't you?
Yes, I've lost over 5 stone.
And what is that in pounds?
70.
70 pounds, Dr. Sam?
Yes, that's right.
Wow, that's a lot.
Yeah.
Wow. So that has also helped you to feel better? Thank you, Dr. Sam. It's nice to have an expert in the house.
So yes, that has been hugely beneficial.
Well, that's good. And for the listeners who may not understand why you can't go swimming, can you talk about that?
I was basically told by one of the doctors that actually understands these things that it's one of the worst things to do for people with LQTS because due to the amount of strain it puts on the heart muscles, which is really annoying because I have osteoarthritis and it's one of the best things I could actually be doing.
Yeah. People don't realize how good in a cardiac way swimming is. But Frank and I have a child who was a state swimmer, and the water always felt so cold to me. And I remember asking the coach, "Why is the water so cold?" And he said, "Because believe it or not, those swimmers sweat. if the water is warmer, it makes them sweat more and it can actually be bad for them. So they actually have to keep the water at a certain temperature, which to somebody like me who isn't in the water actually doing aerobic exercise, it just feels really, really cold. So I can see why they would be worried about you being in the water, especially since you also have syncope episodes. Nobody wants you to faint in the swimming pool or in a body of water. It could be
Yeah,
fatal.
with me, it was the case that I was overheating in the water. I had to get out the water just so I could throw up and cool down. So it wasn't an issue of the blacking out, it was the other issue I was having when I was in the water.
It's a pity that you can't have the benefit of being in the water for your osteoarthritis
Yeah.
because of your heart condition. We need to come up with some other good solution for you, sweetie. But Frank, you've worked with a variety of people with rhythm problems, and I know you've dealt with a number of people with congenital heart conditions who also have rhythm issues. What special considerations do you have to make for CHD patients that differs from that of people with rhythm issues who have otherwise healthy hearts when you're applying anesthesia?
The major consideration is if the patient has a communication between the atrial septum or the ventricular septum, because you don't have the same kind of consistent pressure changes. So you have to watch for pulmonary hypertension. You have to watch for blood flow issues, atrial blood flows. It requires you to watch all the pressures more carefully. I'm more likely to start an arterial monitoring line for a patient with a CHD, especially if they've got a cyanotic type CHD, one that involves blood flow across the septum. And I tend to watch different leads in terms of the rhythms. I'm a little more careful about sedation. I'm willing to tolerate a little more discomfort in the patient to get an adequate sedation, but not go too far. And obviously, oxygen saturation levels can be a serious issue because the patients don't start out at 95 to 100% saturation frequently. So you have to work with a
Right.
patient who walks in with a room air saturation of 85, and
Mhm.
which means that you have to be very careful about managing their oxygen saturation.
Right. So, when Dr. Sam was talking about all of the efforts he goes to before he even sees the patient with the 3D printed hearts and with the virtual technology that he uses, is that something that Scott and White uses as well?
We have used that sort of thing, but it's uncommon. We don't do that many congenital heart defect patients for electrophysiology procedures. I know of one patient we have where we actually did a modeling of the heart like that. It is common to do the cases with TEE support. We'll do a transesophageal echocardiogram to help monitor the placement of catheters and blood flow during the procedure. But we don't do many CHD patients. It sounds like his specialty brings many more of those kinds of patients to him. Obviously, we do a stronger workup beforehand and look at their prior cases to see what kind of rhythm problems they've had in the past and how the anesthetic was managed. But the 3D printed models of the heart are relatively uncommon for us.
Okay. Thank you. Dr. Sam, in the CHD community, a lot of people develop rhythm problems long after their open heart surgeries. My child's doctor told me this was because of scar tissue that develops on the heart. Aside from scar tissue, are there other reasons members of the CHD community develop arrhythmias later in life? And what can be done to treat them?
Yes, thank you. The reason that heart rhythm problems are much more common in congenital heart disease is mainly three types of issues. One is when the heart isn't normal at birth, maybe the right ventricle is doing the job of the left ventricle, what it wasn't really designed to do, or there was a large shunt between the atria. The pressures and the blood flow volumes in the chamber aren't normal. And the heart is a little bit like a house. Even though we think about the wiring, the plumbing, the building separately, if there's something structurally wrong with the building, it also affects the wiring, the propensity for arrhythmias, heart block where the wiring doesn't complete its job and the heart goes too slow.
Mm.
Beyond that, patients often have had surgery. And the
Mm.
surgery to get access to the valves, the different parts of the heart, will involve a scar in the muscle of the heart. So that scar itself can become a nidus for circuits, kind of like you can imagine a dog chasing its own tail. There's a little pole in the middle. That pole is the scar from prior procedures in the heart. Then a third aspect is over time, the chambers may become enlarged as a result of the surgery. So you're protecting one part of the heart, but that may be transferring abnormal pressures to another part of the heart. And from that enlargement or stretch, you can start getting some other types of heart rhythm problems as well. Fortunately, with modern surgical techniques, the way the surgery is done, it minimizes the amount of scar and the chance for circuits, but it still is very common to have to deal with at least minor heart rhythm disturbances in someone with surgically corrected congenital heart disease.
So, has the more common usage of interventional cardiology helped to prevent more rhythm problems in people?
It's a good question. I would say that on balance, the answer is yes. However, the key is the interventional technique should produce as good a hemodynamic or flow pressure benefit as surgery. If it doesn't, you may have less scar, but you may still have ongoing dilation of the chambers where they become bigger and can get arrhythmias. So that type of decision on which is better for the arrhythmia standpoint is highly individualized. What kind of result do you expect with surgery? What do you expect with intervention? And then you have to look at the risk benefit and advise the patient accordingly.
Is the fact that we have so many more infants that were born with congenital heart disease living to older ages mean that you are seeing more patients just by virtue of the fact that they're living longer and may have even some acquired conditions that lead to electrical problems with the heart?
Thank you. That's an extremely insightful question. You're absolutely right. All congenital heart clinics do see more patients now than we did in the 90s and certainly more than in the 70s for adult congenital heart disease. But the spectrum of rhythm problems we see, just as you anticipated, we see more of the same type of heart rhythm issues we see in the general population, but now appearing with adult congenital heart disease. As an example, the most common atrial arrhythmia in congenital heart disease is atrial flutter,
Mhm.
whereas the most common arrhythmia in the general population in the atrium is atrial fibrillation. And now, with our older adult congenital patients, we often have to think of how best to treat atrial fibrillation with congenital heart disease, something we didn't think much about even as late as, say, 2005 or 2006.
Oh, wow. Yeah, it's amazing to me how much older the population has become. I know when our child was born, we were told that only 1 in 4 infants who survived the Norwood procedure actually lived to the age of 5. And some of the more recent research I've read, it's completely the opposite. Instead of only 1 in 4 surviving, now only 1 in 4 tend to perish. So we actually have at least 75% of the patients who have a Norwood who are born with hypoplastic left heart syndrome surviving to the age of 5 and beyond. It's amazing to me how far we've come in a relatively short period of time. I think congenital heart disease is an amazing field because of that. I don't know if all the other fields out there that deal with the human body have seen such rapid advancements in technology and an improvement for outcome.
Yes, you're right. And still a long way to go. Very important areas for research, for innovation, changes in surgical technique, earlier ages of intervention. and also a large body of research, which I would say is still in its infancy, to try to understand what are the developmental aspects in the developing fetus, in embryogenesis, that we may be able to intervene before we have the structural manifestation of the disorder. So while the cells are migrating, finding their place, there also have been tremendous advances in understanding how we get these mysterious clusters of conditions, congenital heart disease, with maybe a renal problem or other kinds of things. So I think for someone in the next generation, taking care of patients with congenital heart disease will have many more tools in their armamentarium. But you should not also discount the patients and the families themselves for the driving force for survival beyond technology. I mean, I hope Guy doesn't mind me saying this, but you only have to meet him and his parents to understand how someone like Guy is not only doing so well, but thriving to this day.
Absolutely. Embark on a heartwarming odyssey with Baby Heart's Pressure Gateway to uplifting stories for the CHD community. Introducing The Heart of a Heart Warrior book series, inspiring those born with heart defects and their loved ones. Discover the heart of a mother, the heart of a father, and my brother needs an operation. Books celebrating strength, love, and familial support. Visit babyheartspress.com and be part of our loving community, uplifting hearts one story at a time.
You are listening to the CHC podcast. If you have a question or comment that you would like addressed on our show, please send an email to Anna Jaworski at anna@thechcpodcast.com. That's anna@thechcpodcast.com. Now, back to the CHC podcast.
I think patients and families feel more empowered today than ever before. We have a lot more support, and I think we're becoming better medical consumers thanks to the internet and thanks to groups like the ACHA or the Adult Congenital Heart Association. They provide webinars. There are blogs out there that have information. 30 or 40 years ago, there was nothing like that.
Yes, the information is great, but also the courage, the determination, overcoming obstacles over a period of time. A lot of that comes from the patient and the family.
Absolutely. The next question is, what do you think it's important for us to know about arrhythmias in light of it being World Heart Rhythm Week? And Frank, we'll start with you. Did you even know about World Heart Rhythm Week, Frank?
Yes, because of you. I learn a lot because I'm married to you. Since World Heart Rhythm Week applies not only to congenital defects, but everybody, I think the important thing to remember is that anybody can be subject to them. I think you need to be aware of things like palpitations or symptoms like shortness of breath or lightheadedness, which could be indicative of a problem. I think it shouldn't be out of your consideration no matter what your overall health is.
Even the excessive sweating, like Ayrton was talking about,
Right.
that's
Yeah.
another good indicator.
Yeah. And again, you don't want to overdiagnose yourself, but
Right.
it's good to be aware and any degree of concern to consult with somebody who can do a more in-depth analysis of why you're having the symptoms you're having. It may be something innocent and simple, but again, it could be a heart rhythm problem. A quick intervention, something like a smartwatch or just a simple examination by somebody who's qualified, could help to detect if there's a problem. The nice thing about heart rhythms is that if you have a heart rhythm problem, it almost always expresses itself in a way that you can detect by auscultation, listening to the heart. Feeling the pulse rate can be a simple thing. You can detect tachycardia or bradycardia. Everybody should be aware that it can happen and not discount the possibility and access your healthcare resources as soon as you can if you have a problem.
What if somebody doesn't have insurance, Frank? Because I know that's a problem for a lot of people, and they're afraid that going to a cardiologist is really expensive. Do you know what kind of resources might be available to them?
Obviously, the United States not having universal health care is a different environment than a lot of other countries. Like Ayrton is in Scotland and she has health care provided by national health care. But in the United States, if you present at any emergency department anywhere with a potentially life-threatening problem, they will intervene. They will refer you or transport you to a higher level of care if necessary. Now, I don't know what that means in terms of having to pay for it. Obviously, if you have to pay, that can be a hardship, but access to the care will happen. I don't know.
Early intervention is important. And maybe if you don't have insurance, starting by getting a smartwatch just to see what your heart rate looks like. I even saw a ring now that you can wear that gives diagnostic information like your saturation level, which is amazing.
I agree, but there's also the fact that if you're concerned about the cost of your health care, you might be concerned about the cost of your smartwatch too. I think that simple interventions, take your own pulse, feel your own heart rate and count the beats. If you have any concerns whatsoever, if it's irregular or if it's too fast or too slow, and you should know that a normal rate for an adult is 60 to 100 beats per minute. Slightly low or slightly high may just be a temporary thing, but if it's significantly higher or lower, or if it's irregular, then I would immediately have somebody take you, not drive yourself, but have somebody take you to a facility where you can be assessed.
Right. And if you have episodes of syncope or fainting, like what Ayrton did, that's a surefire sign that you need to be seen by somebody, isn't it?
I think so. I think syncope is abnormal, and there are so many possible causes for it. It could be an endocrine problem, it could be diabetes, it could be rhythm problems, it could be a neurological problem. There's so many possibilities, but I think that being assessed for it is understandable because anybody who's subject to syncope can have serious accidents because of the syncopal episodes.
Right. Thank you, Frank. Dr. Sam, what do you think it's important for us to know about arrhythmias in light of it being World Heart Rhythm Week?
Thanks. Yes. So first of all, arrhythmias are very common. Almost every human being will experience some sort of arrhythmia during the course of their lifetime. It's also important to note that not all arrhythmias are malignant. In fact, the majority of heart rhythm problems are not life-threatening and are treated only based on symptoms. So there may be an arrhythmia that's detected, but you may be advised by your physician or care providing group that this is something that if you start noticing, let us know. We can treat. Otherwise, it's something we can observe and maybe periodically check and see how you're doing. A handful of arrhythmias are malignant or potentially malignant. And in those patients, you have to match the right therapy. And often here there will be choices, and the choices you have to discuss in some depth and see which seems to fit you best, having a device in your body, taking medications, or having an ablation procedure. I would say those are the main things I feel are important for awareness. They're common, they're not always dangerous, and it should not be something that controls a person's life or creates fear. Some are malignant, and there are important choices for trying to make it less malignant or take away the excessive risk in you.
Okay, so you've used the word malignant several times in this discussion. And the only other time I've heard the word malignant is when it's dealing with cancer.
Yeah, it is used with cancer very commonly, but the English language use and medical use for benign and malignant come in all fields of medicine. So whenever you have a condition or a symptom and it has some causes that can be life-threatening, we call it a malignant cause.
Okay.
Whereas if in the vast majority of patients does not result in either death or harm or change in their lifespan, but may cause symptoms and require treatment, we call it benign. And that's true for heart rhythm conditions as well.
That's the first time I've heard that. So thank you for teaching me about that. I did not know that.
Sure.
It's helpful to know that most humans will have an arrhythmia. And I think everybody has had a time when all of a sudden your heart starts beating faster than it normally does. Those are not harmful to our heart. It's okay for our heart to start beating faster and then go back to normal. Are there instances where people will be born with arrhythmias and grow out of it?
Yes, that does happen. It's not common, but there is a type of arrhythmia called junctional tachycardia, where the spot in the heart that makes it go fast is in between the upper and lower chamber. It's one of the most common arrhythmias in the fetus. You see it sometimes after birth. It's extremely rare to see it in adult life. Usually within the first 3 or 4 months, it goes away or is treated by the doctors for a couple of years, and then you stop treatment and it doesn't happen anymore. There's also Wolff-Parkinson-White syndrome, where there's an extra connection between the atrium and ventricle. There are a few patients, maybe about 5%, where they may grow out of that as well. It doesn't conduct as well and never causes them any problem throughout their life.
Oh, wow. I didn't realize that. We know that long QT syndrome has a genetic component. Are there other genetic diseases that have an arrhythmia issue along with it?
Yes, there are many, and probably that list is somewhere between 80 to 90 conditions right now.
Wow.
But to give you a few examples, back when I was in training, when a patient's heart was large or weak, we would say idiopathic dilated cardiomyopathy, meaning to say your heart is enlarged and I'm not sure why.
Mm.
Now, we still have that term and we still use it in a lot of patients, but that term is now known to be from several causes, a large number of which is genetic. For example, the top three will be a condition called arrhythmogenic right ventricular dysplasia, where a genetic abnormality that affects the structures that hold our cells together don't work well, the desmosomes. And that gives rise to this type of heart problem. And then another that has to do with how the nucleus protects itself from the rest of the cell, laminopathies. And then several others with muscle proteins, proteins that help the heart muscle to contract, problems with the genes that give rise to those proteins don't work well, and the protein that could make the heart thicker, it could make it thinner, it can make it more likely to get tachycardias. But there's a ever increasing number genetic basis for heart defects, heart problems that are being understood. The most exciting thing to me is it's not just understanding one heart condition, but when there's a constellation of conditions, a defect in the septum, along with a thick heart, along with a valve problem, how those also can be traced back to a development problem and a set of genes trying to direct the developing heart on where those cells should go to. And I think it's fair to say in another 40, 50 years, we probably won't use words like idiopathic dilated cardiomyopathy.
Is it fair to say that maybe in 40 to 50 years we'll be advanced enough to have gene therapy where people can have this diagnosed in utero and possibly even have some kind of treatment so the baby may be born without this issue?
It's actually less than 40 to 50 years. It's right now. There's actually gene-based therapies or so-called biological, including gene-based therapies that are already available for some specific disorders, including some types of storage disorders in the heart that can be treated right now. But will it be mainstream? I would say mainstream, available for many people. I'm more hopeful of something like the 15 to 20-year range.
Oh, that would be amazing. I had not heard of the first three types of heart genetic electrical problems you were talking about. Have those issues been fatal to infants, or is this something that even though it affects the nucleus or even though it affects at the cellular level, the children are still able to grow up?
Yes, we usually see the patients either in their early teens or in adulthood. I've had patients with right ventricular dysplasia that was diagnosed for the first time in his 60s. And I even have a colleague, a physician, who was unaware of having a genetic heart problem even after she was in practice and then had some symptoms and had the diagnosis.
Wow, that is just amazing to me. Frank has been in the operating room at times where they're operating on one particular problem and they notice that a patient has some other congenital problem that has been heretofore undiagnosed, which is just amazing to me. And I think it shows that the human body is just so complex that there are lots of opportunities for things to not be quite perfect, and yet a person can function for many years without ever finding out about it.
Yes, exactly. It's a continuum. And even though we think about normal and disease, it is a continuum. There are conditions which are on the border. For example, 1 out of every 4 adults does have a small defect between the right and left atrium, but it's inconsequential. But you may stumble on it while we're investigating something else, and it becomes a hard judgment to know, is this just by chance diagnosis that has nothing to do with the symptoms, or could it be related and do we need to treat it? So 1 out of 4 means good bet that at least one of us on this call have that and don't know it.
Wow. And I've also been told that bicuspid aortic valves affect a much greater percentage of the population than most people are aware, anywhere from 1 to 3%. And in some people, a bicuspid aortic valve can go undiagnosed their entire lives, but in other people, it can cause major issues.
Yes, that's right. And that's true for many conditions. It partly has to do with the defect itself. What type is it? Does it involve surrounding structures? Part of it also depends on other unrelated conditions that the patient may have that can affect the function of that structure. High blood pressure, wear and tear on that structure. And that's why the diagnosis in one person may have a completely different manifestation, and the same diagnosis in another person may be something they don't even do much about for their lives without a problem.
Just amazing to me. Thank you. You shared way more information than I thought we would get about World Heart Rhythm Week. I feel like I have a much better understanding of the human body. So thank you so much. I feel like I just got a lesson in anatomy.
Thank you.
Okay, Ayrton, what do you think it's important for us to know about arrhythmias in light of it being World Heart Rhythm Week?
That they can affect anyone, that you can be fit and healthy, you can be given a common medication, and you can take it and not realize it can be caused as one of the side effects.
Yeah.
And doctors are aware of this, and you don't get warned about it.
Right. And that's why it's important for you to be your own best advocate and do research yourself, right?
Yes. And don't be afraid to get second opinions.
Mm-hmm.
If I was still listening to my regular doctor, I wouldn't be trying to come off medication now. That is one of the key ones that are known to be causing it.
I imagine it's hard for doctors to let you know about every single side effect, Ayrton, especially in light of what we just learned from Dr. Sam and how
Yes.
the bodies respond differently. Even people with the same birth defect respond differently to treatment or they have different abilities. So I don't know that I want a doctor to tell me every single possible side effect of what I'm taking. However, I do want them to listen to me when I have a concern and let me know, oh
Yes.
my goodness, that could be part of the problem. And I think that was the biggest issue with you was that you brought concerns to your doctor, but you didn't feel heard.
I mean, they had known for over 2 years that I had issues with my heart due to my medications, and they were telling me it was fine. And then when I went back to see them and it had gotten worse, they were still telling me, oh no, it's fine. It's nothing for you to be worried about. But I was fainting. I was constantly going dizzy. And I'm like, no, it's not fine.
No, that's not fine. That's not fine. I'm
And
so
it was
glad that you're a strong advocate for yourself now, Ayrton.
I've had to learn to be.
Yeah.
And it was only after I spoke to a pharmacist who actually explained to me what was going on. And I was like, no, you're not leaving me for another 2 years. I'm like, I'm not having it. I want something done now.
Good for you. You're going to have to come back and let us know if getting off of that drug has impact on your LQTS, because I would love for you to come back on the program and say, I am a former LQTS patient, and now I don't have that problem anymore. And you could be a success story that we get to hear about.
I've got to go for another ECG in May once I've been on the lower dose for 2 months and see if that's making any impact. So we're just playing it by ear because originally they're going to leave me for 6 months. But now they've taken me off this medication, they're moving up the schedule.
Well, that's great. And I'm so glad that you've been willing to share this with the world on the podcast, because there may be other people out there who are having the same kind of symptoms that you had who aren't aware that it could be an electrical problem with their heart. And maybe this will help them to seek help like what you have gotten.
I didn't know it was a thing. I didn't know medications could do this to your heart.
I know there's so much to learn, Ayrton. There's always so much to learn. Thank you for coming on the episode today, Ayrton, as a panelist. I appreciate you.
That's why I do this podcast, to help educate people.
Absolutely. And thank you, Dr. Sam. I feel like I've learned so much from you today.
Completely my pleasure. Thanks for having me on.
And thank you, Frank. I can always count on you to share important information with the podcast team.
I'm glad to help and share whatever I can.
Well, friends, that does conclude the panelist portion of this episode. We're going to take a quick break, and when we come back, our audience will be able to ask questions of our panelists. The CHC Congenital Heart Conversations podcast is a presentation of Hearts Unite the Globe, or HUG, and is part of the HUG Podcast Network. HUG is a nonprofit organization devoted to providing resources to the congenital heart defect community to enrich the lives of our community members. For free CHD resources, please visit our website at congenitalheartdefects.com. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions expressed in the podcast are not those of Hearts Unite the Globe, but of the hosts and guests, and are intended to spark discussion about issues pertaining to congenital heart disease or bereavement. We have 2 members of the audience with us, Nicole and Guy's mother, which I'm so happy to have you back. We'll start with you, Guy. Guy is the producer of this podcast episode, so welcome to the CHC podcast, Guy. Thanks for working behind the scenes. What's your question?
Very more happy you, Dr. Asivatham. Without you and your team, I would not be standing here. Literally.
Thank you, Guy. It's been an incredible pleasure, and you have inspired not only many people in our team, but so many others in how you and your family have gotten to the point where you're at. I appreciate that.
Thank you as well.
Okay, Nicole. Nicole is one of our CHC podcast volunteers. What's your question?
Mine is both a statement and a question. Of course, my ears perked up when you talked about bicuspid aortic valve and how some people can go their entire life with them not being diagnosed. And I have noticed in some of the groups that I'm in, there seems to be an influx of people in their 30s, 40s, and 50s who are just now getting diagnosed with that condition and went their entire lives like me, never knowing that they had any kind of issue. That being said, my question is for Dr. Sam. Since my surgery, I have a left bundle branch block. That's known. My cardiologist isn't concerned about it. I don't have any symptoms. He said the only thing that would be concerning is that if I ever had symptoms of having a heart attack, they wouldn't be able to tell whether or not I actually was based on the EKG. I would have to go to the cath lab. So do I need to let other medical professionals know, especially if I go to the family doctor or if I'm going for something where I need a physical for work? I don't want somebody to do an EKG and then them start to panic that there's a problem.
Yes, thanks, Nicole. Just for everyone, what left bundle branch block is it's not a block in the arteries, but in the wiring of the heart. The electrical message comes from the top to the bottom chamber through one wire that splits into two, one that goes to the right ventricle, one that goes to the left ventricle. As long as one of them is working, that's enough to get the heart activated. When one of them isn't, and if it's the left one that isn't working, and that's frequently seen after surgery near the aortic valve, it's called left bundle branch block. By and large, you don't have to do anything about it. As you get much older, there is a slight increase in either the heart weakening or potentially needing a pacemaker. This is more of an issue maybe in your mid-70s, some years down the road. In terms of heart attack diagnosis, what your doctor said is important. To diagnose a heart attack, we actually use three things: the story, the history, what type of chest pain it is the person is having, then some tests for looking at enzymes that are normally in the heart cells, but spilling over into the blood. And those two parts are the same in a patient with left bundle branch block or not. The third part of the diagnosis is the ECG. The ECG diagnosis for a heart attack with left bundle branch block is much harder than in people who don't have that. It's still possible to do it, but if it's not that clear from the ECG and the blood tests and the history also are not clear, equivocal, then an angiogram is the best way to make the diagnosis. But it doesn't mean that everybody with left bundle branch block requires an angiogram to make the diagnosis. It may still be required to treat the heart attack, though, with a stent or opening up the blood vessel.
Thank you so much.
It was an excellent question and an excellent explanation. Thank you so much. Ayrton, you're next.
Yeah. Like Nicole, something that Dr. Sam was talking about that caught my interest was the idiopathic dilated cardiomyopathy, because that was something that was picked up on at my brother's autopsy. His coroner who carried out his post-mortem did mention that he had an abnormally large heart, but obviously he couldn't be 100% certain if that was anything to do with his cause of death or not.
Yes, Ayrton, that's extremely important information. So if you look at people who died suddenly without any known cause, sudden cardiac death, the reason just before death, what happened is the heart went into ventricular fibrillation, an extremely fast heart rhythm from the lower chamber. But why did this ventricular fibrillation happen? If we take 100 people who had sudden cardiac death from ventricular fibrillation, about 60 or 65, it will be because of a heart attack that caused this fast heart rhythm. And another 20, it will be because of a dilated cardiomyopathy of some kind, where the heart muscle was abnormal. So if we take away heart attacks, what your brother had as an enlarged heart is the most common finding at autopsy in patients who died suddenly. And that is something that could have a genetic basis. It could also have an acquired basis. So it could be from a viral infection, could be from excessive alcohol use, certain other medications, but it's also multiple genetic disorders that can cause it. It is possible to do what's called a molecular autopsy, where after someone passes away, just like we do a microscopic autopsy, you can do genetic testing on the heart or heart samples as well. but it is one of the most common findings in someone who dies suddenly.
Okay, thank you.
Well, friends, I can't believe it. This recording has gone by so fast, and it's already time for us to say goodbye to everyone. So I want to thank our producer, Guy Simke, today for not only producing the show, but for also finding Dr. Sam and coming up with the idea for us to do this episode to begin with. This has been so educational, and I know it's going to help a lot of people. I want to thank all of you for joining us today and thank our panelists one more time, and Nicole Bilodeau and Mom Simke for coming and being part of the studio audience. We really appreciate you. I hope you'll join us next month for our episode on CHD warrior siblings to adults with CHDs. And until then, I'm Anna Jaworski. Have a great day and keep those congenital heart conversations going on Facebook, Instagram, and TikTok.
Thank you for joining us. The CHC podcast can be heard monthly wherever you get your podcasts. Visit us on Facebook or Instagram to continue the conversations. Join the Hearts Unite the Globe Patreon group and become part of our town hall meetings. It's simple. Just visit www.heartsunitetheglobe.org and select the tab that says Donate to Hug with Patreon. Then you too can be part of the conversation.